হ্যালো, হ্যালো, মুরলী, হ্যালো, দুজন জয়েন করেছে, চারজন দেখালো। হ্যালো, না কেউ আছে কি না দেখি জয়েন।
Good morning, sir.
হ্যাঁ, শুরু করবো। হ্যালো,
Yes, sir.
হ্যালো, am I audible?
Yes, sir.
Yes, sir, you are audible.
Slides visible? Hello, slides are visible?
Yes, sir.
All right, so I am starting. Today our topic is, as per your request, acute renal failure, or it is now being called as acute kidney injury. Okay, acute renal failure or acute kidney injury, AKI. So definition: a clinical syndrome in which sudden deterioration of renal function, acute, so it is sudden, results in inability of the kidneys to maintain fluid and electrolyte hemostasis. Very simple. Also known as acute renal insufficiency or acute renal failure or AKI, as I have told. Incidence is not very less. 2 to 3% of children admitted in pediatric tertiary care center, we used to get this percentage of cases. But it is bit high in NICU. 8% of infant in neonatal ICU we used to get having acute kidney injury, mostly following birth asphyxia or severe birth asphyxia, and also from septic shock. So P rifle, we know rifle criteria, and in pediatrics it is known as pediatric modified rifle criteria for your classification of AKI. Criteria is estimated creatinine clearance and urine output. So rifle means risk, injury, failure, loss, and end-stage renal disease. So when we will call the patient is at risk of having AKI, if the ECCL, when estimated creatinine clearance decreased by 25%, and urine volume is less than 0.5 ml per kg per hour for 8 hours. Simple. Injury, when we will call injury, if the estimated creatinine clearance decreased by 50% and urine output less than 50 ml per kg per hour for 16 hours, then when we will call it failure, if the estimated creatinine clearance decreased by 75% or urine volume output less than 0.3 ml per kg per hour for 24 hours or anuric for 12 hours. We will stamp that case as having failure. Then when we will call loss, if the failure persists more than 4 weeks, and when we will call end stage, persistent failure for more than 3 months. So before 3 months, we can't say patient having end stage renal disease. So this is a very important classification, also known as P-rifle criteria: risk, injury, failure, loss, and end stage renal disease. So these are the few causes. We know very well AKI may be pre-renal, intrinsic or renal or post-renal. And in children, mostly we used to get pre-renal following dehydration, hemorrhage, sepsis, hypoalbuminemia, and cardiac failure. These are the pre-renal causes. And intrinsic or renal causes, it is, post-infectious or other post-infectious, post-streptococcal glomerulonephritis, lupus erythematosus, Henox Colen, membranoproliferative, antiglomerular basement membrane disease, and hemolytic uremic syndrome. Antiglomerular basement membrane, another name is good pasture, and hemolytic uremic syndrome, acute tubular necrosis or ATN, cortical necrosis, renal vein thrombosis, rhabdomyolysis, acute interstitial nephritis, and tumor infiltration. And postrenal, most commonly we used to get posterior urethral valve, very common in male children. And other than this, ureteropelvic junction obstruction, ureterovesicular junction obstruction, ureterocele, tumor, urolithiasis, hemorrhagic cystitis, and neurogenic bladder. These are the very common causes of postrenal causes of AKI. And among these, most important is posterior urethral valve. So, lab findings. So, anemia, very commonly we used to get. Anemia is mostly dilutional or hemorrhagic, hemolytic rather. And anemia because renal failure because of hemolysis we usually get in SLE, renal vein thrombosis, and hemorrhagic uremic syndrome. Leukopenia, SLE and sepsis. Thrombocytopenia, SLE, renal vein thrombosis, sepsis, and HUS. Hyponatremia mostly dilutional, but total sodium may be high. But because of excess fluid accumulation, sodium level may be low. And metabolic acidosis, one of the important clinical features. And also we will get elevated blood urea nitrogen, creatinine, uric acid, potassium. Again, potassium very common cause of death, hyperkalemia, and phosphate, increased level of phosphate. All these are because of diminished renal function. And hypocalcemia. Hypocalcemia, it is because of hyperphosphatemia. If the phosphate levels goes high, obviously calcium will go down. So these are the features. And C3 is very important marker. Post-infectious glomerulonephritis, SLE, and membranoproliferative glomerulonephritis. And we know MPGN is a significant lesion nephrotic syndrome. And C3 level is so important in post-infectious glomerulonephritis, rather post-streptococcal glomerulonephritis, that if the C3 level is normal in a suspected case of post-streptococcal glomerulonephritis, we can exclude. It is so much so. Antibodies, streptococcal, PSGN, anti-streptococcal antibody, ASO, nuclear antibody, anti-nuclear antibody or ANF, SLE, neutrophil cytoplasmic antibody, very common in Wegener granulomatosis, microscopic polyarthritis, and basement membrane, glomerular basement membrane in Goodpasture disease. They are the antibodies we used to get. And now this is very important. Very important. Urine analysis, urine chemistries, and osmolarities in acute renal failure. Suppose if it is a pre-renal or hypovolemia, there will be usually no sediment, or if you get, it will be bland. Protein none or low. Urine sodium less than 20 milligram per liter. Osmolarity more than 400. And fractional excretion of sodium is less than 1. So these are the, if we get this, we can say this is a pre-renal cause of renal failure. Now, acute tubular necrosis or ATN, renal cause. Renal cause, you see here acute tubular necrosis, acute interstitial nephritis, and glomerulonephritis. All are, or in these three are renal cause, but can be differentiated from urine features. So in ATN, sediment will be broadcast, brownish granular cast you will get. Protein usually no or very low. Urine sodium here will be more than 30 milligram per liter. Urine osmolarity here will be less than 350, and fractional excretion will be more than 1. Whereas in acute interstitial nephritis, white blood cells, eosinophil, cellular cast in the sediment, minimal but may increased protein, especially if it is because of NSAID. Urine sodium usually more than 30, urine osmolarity less than 350, and fractional excretion more than 1. And Usually one, but it varies. In ATN more than one, but in interstitial nephritis it varies. Now, if it is a case of glomerulonephritis, or suppose renal failure developed from acute post-streptococcal glomerulonephritis, red blood cells and red blood cell cast in the urine. Protein will be increased obviously, more than 100 milligram per dl. Urine sodium will be less than 20. Urine osmolarity will be more than 400, and fractional excretion of sodium will be less than 1. And if it is a obstruction or acute renal failure from obstruction, a sediment will be usually bloody or bland depending upon the cause. Protein very low. Urine sodium in acute, immediately after obstruction, it will be less than 20. But after a few days, it will be more than 40. Urine osmolarity will be less than 350, and fractional excretion less than 1 in acute stages and more than 1 after few days. So following this, if we follow this chart, very clearly we can differentiate the common causes of AKI from the urine. Now you see, sensitivity and specificity of urine sodium less than 20 in differentiating prerenal from acute tubular necrosis are 90% and 82%. So urine sodium estimation is very, very essential. And what is fractional FeNA or fractional excretion of sodium? Urine is to plasma ratio of and divided by of sodium divided by urine and plasma creatinine. That means urine is to plasma ratio of sodium divided by urine and plasma of creatinine into 100. This is the definition of or calculation of FeNA. And sensitivity and specificity of fractional excretion of sodium is less than 1% in differentiating prerenal. As I have told, in prerenal it is less than 1%. From acute tubular necrosis it is more than 1%, and it is 96% sensitive and 95% specific. So these two, you remember these two parameters. Is very much essential in differentiating renal from prerenal cause of AKI. Chest X-ray, if you do chest X-ray, cardiomegaly and pulmonary congestion because of the fluid overload or pleural effusion. Renal ultrasound, hydronephrosis, hydroureter, nephromegaly, suggestive of intrinsic renal disease. And renal biopsy, usually not required, but who do not have clearly defined prerenal or postrenal ARF, sometimes renal biopsy may be indicated. So other biomarkers are recently developed biomarkers, because so far we know creatinine, but creatinine level will be high, but it will take much time. So there are some recent advances in biomarkers which can pick up AKI very early. One is plasma neutrophil gelatinase associated lipocalin, NGAL, or cystatin C. Very early they will rise. And other changes and other factors, urinary changes in NGAL. Initially I told plasma, now you see urinary NGAL, interleukin 18 and kidney injury molecule or KIM1. These three tests are available in the urine sample, and above two in the plasma, NGAL and cystatin C level. Very important early biomarkers. So now management, very simple management. So catheterization first. In newborn with suspected posterior urethral valve, it is urethral valve, and non-ambulatory older children, you catheterize and be certain that there is no urine. If there is no evidence of volume overload or cardiac failure, intravenous administration of isotonic saline. তার মানে প্রথমে তোমরা শিওর হয়ে নাও there is no volume overload or no cardiac failure, then you give one challenge of isotonic saline, 20 ml per kg over 30 minutes. 20 ml per kg over 30 minutes. Now you see, hypovolemic patient generally void within 2 hours. If the renal failure is because of hypovolemia or prerenal rather, that patient will pass urine within 2 hours. And if there is failure, points to intrinsic or post-renal ARF. Very simple. But hypotension due to sepsis, vigorous fluid resuscitation followed by continuous infusion or norepinephrine is required. Hypotension due to sepsis, vigorous fluid resuscitation followed by continuous infusion of norepinephrine is required. Now, you have given fluid, patient not passing urine, still you are suspecting there is a chance of renal cause, you start diuretics. But that should be given after fluid resuscitation. Initially, you give mannitol 0.5 gram per kg and furosemide 2 to 4 milligram per kg as a single IV dose. Mannitol usually works when this failure is because of the pigment, myoglobin or hemoglobin, induced renal failure. And bumetanide you can give 0.1 milligram per kg alternative to furosemide. But we usually give mannitol and furosemide. If still urine output not improved, continuous diuretic infusion, furosemide, can be given. Along with that, you consider dopamine, 2 to 3 microgram per kg per minute in conjunction with diuretics. There is little evidence that diuretics or dopamine can prevent ARF or hasten recovery. Evidence nahi, kintu we can try. Still, in spite of this fluid and diuretics therapy, patient not responded, you stamp that case as renal failure, either renal cause because of the renal cause or because of post-renal cause. Now you start treatment. First and foremost is hyperkalemia because it is a very, very common cause of death. If the potassium is more than 6 milliequivalent per liter, that can cause cardiac arrhythmia, cardiac arrest, and death. And that you can get some ECG changes, earliest ECG changes. Very common question. Peak T wave followed by widening of the QRS intervals, ST segment depression, ventricular arrhythmia, and cardiac arrest. These are the features of hyperkalemia. What you will do? First, you stop exogenous sources of potassium. That may be dietary, intravenous fluid, total parenteral nutrition. That should be stopped. Then you give sodium polystyrene resin sulfonate, K-xylate, orally or by retention enema if the potassium is more than 6 milligram per liter and dose is 1 gram per kg. So what this will do? This will exchange sodium for potassium. Sodium will go in, potassium will come out. But problem is that it can take hours to show its effect. A single dose 1 gram per kg can lower the potassium level about 1 milligram per liter. Resin therapy may be repeated every 2 hours, the frequency being limited primarily by the risk of sodium. Because more you give sodium polystyrene resin, more sodium will go in and chances of hypernatremia will be there. Now if you get potassium is more than 7 milligram per liter, emergency measures to be taken. Otherwise, patient will die. But these are given along with the K-xylate. Calcium gluconate 10% solution 1 ml per kg IV over 3 to 5 minutes. Sodium bicarbonate 1 to 2 milligram per kg IV over 5 to 10 minutes. And regular insulin 0.1 unit per kg with glucose 50% solution 1 ml per kg over 1 hour. What insulin and glucose will do? It will push the cell from outside, push the potassium from outside cell to inside the cell, and that your potassium level will come down. Along with that is sometimes nebulization with beta-2 stimulant, salbutamol may be helpful, but doubtful in pediatrics. Now, metabolic acidosis, common in ARF as I have told, rarely requires treatment, but if severe metabolic acidosis, characterized by arterial pH less than 7.15, serum bicarbonate less than 8 milligram per liter, or contributes to hyperkalemia, it should be corrected. That means hyperkalemia is because of metabolic acidosis. Because we know In acidosis, potassium level will come out from the cell. So until and unless you correct the acidosis, potassium level will not go down. So hypocalcemia, primarily treated by lowering the serum phosphorus level. As I have told initially, hyper hypocalcemia is because of the hyperphosphatemia. So if you lower the phosphorus level, calcium level will come normal. Calcium should not be given IV except in cases of tetany to avoid deposition of calcium salt into tissue. Calcium phosphate salt will be deposited in different tissue. So until and unless there is tetany, IV calcium is not given, and follow a low phosphorus diet. Phosphorus intake should also be restricted. Hyponatremia, very, very common. Most commonly dilutional. So can be treated by fluid restriction. Or if the patient is symptomatic, hypertonic saline, 3% saline can be given. Symptom means seizure, lethargy, convulsion, or other. And also if the no symptom but potassium, sodium is less than 120 milligram per liter. In that case also you have to give sodium 3%. GI bleeding, very common, can cause because of acute uremic platelet, because of the uremic platelet dysfunction, and increased stress and heparin exposure in hemodialysis can also cause. Treated by oral or intravenous H2 blocker, ranitidine, along with blood transfusion, that I am coming. So hypertension, very common along with this acute kidney injury, and it is mostly found in renal causes, glomerulonephritis or hemolytic uremic syndrome. First and foremost is salt and water restriction and diuretics. And antihypertensive like irzadipine, amlodipine, propranolol, or the blood pressure is very high, labetalol in this 4 to 40 milligram per kg per 24 hours divided BID or TID can be given. And severe symptomatic hypertension, continuous infusion of sodium nitrophosphatide or esmolol. Continuous infusion of sodium nitrophosphatide or esmolol can be given. Neurologic symptom, headache, seizure, lethargy, confusion. That means because of the encephalopathy. And potential etiologic factors here are hyponatremia, hypocalcemia, hypertension, cerebral hemorrhage, cerebral vasculitis, and uremic state. These are the potential causes of your encephalopathy. And mostly treated with diazepam if there is a convulsion and you treat the underlying cause. Anemia, as I was telling, generally mild. If hemoglobin is less than 7 gram per dl, packed red cell can be given, and very slow over 4 to 6 hours, 10 ml per kg, diminishes the risk of hypervolemia. Because this type of patient may be hypervolemic, so we have to be very much cautious. Slow transfusion usually preferred. Nutrition, in most cases, sodium, potassium, and phosphorus should be restricted. Protein restricted, but calories should be given maximized, and it should be given from the carbohydrate and fat to reduce the accumulation of nitrogenous waste. And critically ill patient with ARF, parenteral essential amino acid can also be given. Protein, enough protein for growth, because otherwise that will limit the growth of the disease patient. And if patient is on dialysis, protein should also be increased. And foods with protein include, these are the protein containing food: egg, milk, cheese, chicken, fish, red meats, beans, yogurt, and cottage cheese. Sodium depends on the stage of their kidney disease, their age, and sometimes other factors. Foods high in sodium include canned food, some frozen food, most processed food, and some snack foods such as chips. These are the high sodium containing foods usually should be avoided, and in hypernatremia fluid restriction is sufficient. And potassium, uh, because these patients are usually having hyperkalemia, so potassium intake should be restricted, and these are the low potassium on the your left side: apples, cranberries, strawberries, blueberries, raspberries, pineapple, cabbage, boiled cauliflower, and mustard greens. These are the low potassium. And high potassium: orange, melon, apricot, banana, potato, tomato, sweet potato, cooked spinach. They are the high potassium, should be avoided. And is a no one, a pediatrician cannot or nephrologist cannot himself manage. So it's a team management: pediatrician, nephrologist, dialysis, transplant coordinator, transplant surgeon, social worker, financial counselor, and dietitian. So it is a team approach for management of AKI. So, and ultimately dialysis will be required. Dialysis will be required. So dialysis indications key: volume overload with evidence of hypertension and or pulmonary edema refractory to diuretic therapy, persistent hyperkalemia, severe metabolic acidosis, unresponsive to medical management, neurogenic symptoms, means altered mental status, seizure, blood urea nitrogen 100 to 115 milligram per DL and lower if rapidly rising, calcium phosphorus imbalance with hypocalcemic tetany. Thank you. So any question? Hello, Rajdeep. Hello. হ্যালো।
হ্যাঁ স্যার। হ্যাঁ স্যার।
ও কেমন লাগলো?
স্যার ভালো লেগেছে, কিন্তু আমি টোটালটা আজকে অ্যাটেন্ড করতে পারিনি।
এত attend
আমি
করতে
লাস্ট কয়েকটা স্লাইড করতে পেরেছি।
তাহলে আমি প্রথম থেকে একবার র্যাপিড দেখিয়ে দিচ্ছি, দেখো।
হ্যাঁ।
এটা ডেফিনেশন দেখো,
হ্যাঁ স্যার।
তারপরে দেখো রাইফেল ক্রাইটেরিয়া, হ্যাঁ, এটা ইউনিক ক্লাসিফিকেশন। তারপরে দেখো এটা প্যাথোজেনেসিস, কজ, প্রিরেনাল, রেনাল অ্যান্ড পোস্টরেনাল। তারপর দেখো ল্যাব ফাইন্ডিংস: অ্যানিমিয়া, লিউকোপেনিয়া, থ্রম্বোসাইটোপেনিয়া, হাইপোনেট্রিমিয়া, মেটাবলিক অ্যাসিডোসিস, C3 লেভেল ডিক্রিজ, অ্যান্টিবডিজগুলো পাওয়া যায়। আর এইটা হচ্ছে ইউরিন এক্সামিনেশন করে রেনাল, প্রিরেনাল, পোস্টরেনাল। রেনালের আবার অ্যাকিউট টিউবুলার নেক্রোসিস, অ্যাকিউট ইন্টারস্টিশিয়াল নেফ্রাইটিস, গ্লোমেরুলার নেফ্রাইটিস আমরা ভাগ করতে পারি। আর FeNA and urine sodium estimation is very much essential. Both cases it is sensitive, more than 90%. CXR, renal ultrasound, biopsy usually not done. These are the new biomarkers: NGAL, cystatin in serum, and urinary NGAL, interleukin 18 and KIM, kidney injury molecule. Management: catheterization first, then correction by saline challenge, then diuretics. If urine output not improved, dopamine can be started. Hyperkalemia management: this is the severe hypokalemia. Management of your metabolic acidosis. Hypocalcemia management, hyponatremia management, GI bleeding management, hypertension management, neurologic symptoms, anemia management, nutrition very much essential. Protein: these are the protein which should be customized according to requirement, age. Sodium usually avoided. Fluid restriction is sufficient to correct the dilutional hyponatremia. This is the potassium, low potassium diet prescribed, and health team is essential, and dialysis indication. Thank you. Clear?
ক্লিয়ার স্যার।
Next class.
স্যার বলছি, আর একটা কোশ্চেন ছিল, বই কি কিনবো স্যার?
all the
স্যার শুনতে পাচ্ছি না।
things I have told here from Nelson. Nelson
Okay.
nephrology is unique. Huh?
ঠিক আছে,
No
ঠিক
need
আছে।
of other books, only you go through Nelson. Both
ওকে
acute
স্যার,
renal failure and also chronic kidney disease.
ওকে স্যার।
কি ক্লাস করতে চাও অন্য সিস্টেম বলো? এই তো
স্যার সিবিএস,
নেফ্রোলজি তো হলো, তাহলে সিবিএস পড়া যেত।
সিবিএস স্যার।
এরপরে
হ্যাঁ সিবিএস, সিবিএস।
সব প্রত্যেকটা জিনিস একটা একটা করে বলে দিই, ঠিক আছে?
ঠিক আছে স্যার,
দেন আই এম লিভিং।
থ্যাংক ইউ স্যার।